Good evening, everyone. It's my pleasure to welcome you to this webinar sponsored by Bayer, organized by the ESU. The topic of today is non-metastatic CRPC, a major topic, practically speaking, and a major topic for patients. Recently, we had trial that clearly suggested that there is survival benefit to treat some of them, and there is not only a survival benefit, but a symptom-free benefit period when you treat them initially. So with two friends, we will try to elaborate a little bit on that. And it's my pleasure to welcome Professor Jan Altenburg. We'll try to clarify how to select the best patients to be treated with one of these three drugs and how to best select the best candidates. And Professor Romain Mathieu will try to elaborate a little bit on something that is often forgotten in practice, that is bone health. We all know the evidence for bone health management in metastatic castrate resistance. We also know the management of bone health during androgen deprivation therapy, but there might be some specific points to consider in non-metastatic CRPC, and Romain will elaborate a lot on that. Before starting the first talk, let me remind everyone that there is a Q&A button in the bottom right of the screen, middle right of the screen. So if you have any questions, just ask them through the Q&A, and we will do our best to answer them either directly by typing the answer or orally. When we have done all three talks, we'll still have time to discuss any burning questions you might have or interact. So be interactive. That might be the best way to go. So the first talk is, from me, real world evidence versus randomized controlled trials. Are there differences? You might find the topic a little bit surprising, but you will see it's not that surprising. My disclosures with the pharma industry. Okay, let's start to clarify something, and this will go back to real life. The castrate-resistant prostate cancer has a very clear definition. The very clear definition is a castrate level of testosterone, absolutely mandatory to check, which is below either 50 nanograms per deciliter or below 1.7 nanomole per liter. And as we are dealing with non-metastatic patients, it's only defined by a biochemical progression. And the biochemical progression is not completely trivial. It's defined very precisely as 3 consecutive rise in PSA, minimum a week apart, that should result in a 50% increase over the nadir. And this end is very important, the PSA must be above 2 nanograms per ml. This is the kind of patients we're discussing, castrate patients with a biochemical rise. We all know that the non-metastatic, and Jan will elaborate on that about the imaging modality. All the trials, all the 3 trials that you are aware of, used almost the same design. All the patients were M0, and that was based on bone scan and CT scan. And I insist on that there was absolutely no use of PET PSMA. There are a little bit difference in terms of nodal disease allowed in the pelvis, but that's, for me, it's a detail. The PSA in all patients was above 2 nanograms per ml, and the absolute inclusion criteria with the PSA doubling time that was less than 10 months. Let me remind everyone, the doubling time is calculated using 3 values of PSA, all of which above 0.1. Stratification was based on the doubling time more or less than 6 months, and the use or not of bone protective agents. And finally, for some of them, the fact that patients were N0 or N1, that is purely pelvic nerves. Randomization was 2-to-1 for all the 3 trials, and all the 3 trials had the same primary objective, that was metastasis-free survival. That is, metastasis or death. And as you know, all the 3 trials were positive. Spartan using apalutamide, Prosper using enzalutamide, and Aramis using darolutamide. All 3 trials are positive. A difference in med-free survival of around 20 plus months. Hazard ratio is very significant, around 0.3, and the p-value has a lot of 0 following the point. So no problem, no discussion. The trials are positive. Let me highlight something here, that the vast majority of patients in all 3 trials had a PSA doubling time below 6 months, so a very rapidly progressing PSA. The second, to clarify, that's also important, these trials cannot be directly compared, and you cannot say this hazard ratio is better, or that's the best trial, bad drug. The trials are independent, and we have 3 independent positive trials. The secondary objective, that was not the primary, is overall survival, and once again, the 3 trials are positive. From the left to the right, Spartan, Prosper, and Aramis, absolutely no discussion. The 3 trials are positive. Even more important, this benefit is there despite crossover, and crossover was not so trivial, up to 30% in Aramis. What does it mean? 30% of the patients who were allocated to placebo were switched to active therapy, in that case to darolutamide. So the trials are very positive, and you clearly improve the survival when you treat these patients as they are included with any of these 3 drugs. Once again, you cannot say drug A is better than drug B or C. Trials are completely independent. If you improve the survival, there's a cost, there's a price to pay. I'm not talking about money, I'm talking about quality of life. And this is very reassuring. In all 3 trials, there was absolutely no signal that any of these drugs was detrimental in terms of quality of life. So you delay the mets, you prolong the overall survival, and there is a very stable and consistent quality of life. That's absolutely good. But all the drugs have side effects. And I will come to that in details, because this is where real life data might be of major importance. Once again, if you see, the drug was quite well tolerated. If you see the treatment stops based on side effects, you see it's not that much. Let's say around less than 10%. The death rate directly due to the drug itself seems to be absolutely acceptable. It's marginal. I'm not saying it's 0. It's from 0.1% to roughly 4%. Once again, you cannot compare the 3 drugs. Just have a look at the dropout rate in the placebo group and the death rate reported from side effects in the 3 trials. Why should a placebo lead to 0.3% death rate in a trial and to 3% in another trial? A placebo has absolutely no direct effect. To me, that's a major signal to suggest that you cannot compare the trial. What you might say is roughly the trials are as effective, as toxic in terms of this kind of toxicity. If you're going to go to more details, there are still some differences in the 3 trials. Once again, in the trials per se. First of all, the placebo. The placebo, there's a difference, and once again, there's an argument not to directly compare the 3 trials. Just have a look at the monitoring schedule. Every 16 weeks in 2 trials, every 4 weeks initially in 1 trial, then every 8 weeks, then every 16 weeks. The more closer you follow, the higher the rate of placebo side effects you see. It's not such a surprise. What happens if we go for detailed side effects? With apalutamide, it's mostly fatigue, hypertension, rash, and hypothyroidism. With Prosper, that is with enzalutamide, it's again fatigue, hypertension, and falls. Hypothyroidism was not reported. In darolutamide, it's again hypertension, and you see some side effects. In terms of hypothyroidism, there was almost no hypothyroidism. Falls and fractures, roughly 4%. So the toxicity profile in these included patients' population are a little bit different. That's led to a guidelines proposal that's a strong recommendation that any of these 3 drugs should be offered to patients with a PSA above 2 and a PSA doubling time below 10 months. That's where the guidelines are and the randomized trials are. But these are from guidelines. These are from trials. Is real life equivalent? We know very clearly that the results seen in trials are completely different compared to results seen in real life. To highlight this, I just show you an example. It's an example of metastatic castrate-resistant patients, all treated in Princess Margaret Hospital, where Jan Tannock is working. For those who don't know, Jan Tannock was the key leader, was the PI of the TAX 327 and was the key leader for docetaxel in metastatic castrate-resistant prostate cancer. All the patients were treated in his team, the same nurses, the same doctors. Just have a look. These are the results from the TAX 327. The entire cohort of patients, median survival 19 months. These are the patients treated in Princess Margaret Hospital by the same team, median survival 20 months. And here are the 314 patients treated in Princess Margaret Hospital by the same team that treated those patients, and the median survival is suddenly only 14 months, 13.6 months. Clearly, the patients had not the same selection criteria. Once again, they were treated by the same team. So real-life data is absolutely needed. And we might see differences. To my knowledge, nothing has been published yet on real-life data with any of these 3 drugs on non-metastatic CRPC, but that would be absolutely lovely to be sure that the benefit is maintained in real life. Why might it be so important? There was a lot of selection criteria in all the 3 trials. We all know that patients are sometimes young, but very often are not so young, and so have a lot of comorbidities. You have here a non-complete list of comorbidities. And none of these comorbidities, almost none of them, were exclusion criteria for the inclusion. Some were exclusion criteria, like recent severe cardiovascular morbidity, or in one trial, the history of seizure. But the real-life population might be completely different. So we might see issues with these patients. And what kind of issues? Probably one of the most important is drug-drug interaction. There is a theory between the 3 drugs that have a little bit different. The drug-drug interaction is not trivial. It might be in different ways. The first thing is the addition of the AR antagonist might modify the concentration of other drugs, because the antagonist might have an impact on these kind of enzyme or drug transporters. You see the profile of the three drugs is different. The inhibitors, some drugs used to treat comorbidities might have a direct impact on the AR concentration. Some of these drugs might be inhibitors. Some of these drugs might be inducers. If it is an inhibitor, it increases the ER concentration. If it is an inducer, it decreases the AR concentration. And once again, the profile of the drugs are different. So this might mean that in real life, we might see a different rate of toxicities or a different way of efficacy. An example of drug-drug interaction regarding the various drugs that you might see, and you see there are a lot of interaction, but once again, it seems that darolutamide here might have a better safety profile regarding drug-drug interaction. It does not mean it has no interaction, it does, but it seems to have less compared to APA or N. The second important point regarding real life is the follow-up strategy of patients. In the trials, the patients were followed on a very regular basis. As I already said, in Spartan with apalutamide, very closely initially, and that up to every 16 weeks, when the two other, patients were followed every 16 weeks. And they were only followed by clinic, biology, sure there was no toxicity, and images. Images were repeated every 4 months. Bone scan and CT scan were repeated every 4 months. And all of them had a central confirmation. And we know that sometimes the central confirmation and the local reading might be different in both directions. So the last message regarding this is, when do we need to change therapy outside drug toxicity? In all three trials, that's probably the second most important message here. In all three trials, the change of therapy was only decided because of progression. Progression only by either bone scan or CT scan or symptomatic progression. PSA progression was never considered as a signal of disease progression. Therefore, if we want to apply the results of these three trials in every practice, we should resist to change the therapy just because the PSA is rising. And this is perfectly in line with the PCWG2 and 3 definitions that have been fully published now. The biological follow-up, that's it. Nothing special. You need to follow the PSA, but remember, you need to also to explain to the man facing you that in case the PSA is rising, it's not equal to the disease is progressing, which is exactly the opposite that all has been done before. When we added ADT because of disease progression, mostly on PSA, we consider disease progression just because of PSA, we define the disease just because of an elevated PSA. Suddenly, the value of this PSA is completely different. So the key messages here are PSA must be above 2. Honestly, a second opinion, I see some patients that are propose this kind of drugs with a PSA below. That shouldn't be the case. And the doubling time should be below 10 months. Staging should be done only on bone scan and CT scan, and the follow-up should be done every 4 months using clinic, biology, and above all, imaging, and never, ever considering changing the drug just because of PSA. We really need to be sure that this is followed. If it's not followed, we might change therapy far too early. We might include patients that are not usually included in the 3 trials, but we need to have real life data, and to have them, we need to have prospective database. Happy to answer any question you might have, and I give the mic to Jan Oldenburg that will elaborate more on patient selection. Jan, the floor is yours.
Thank you very much. Can you see my slides?
Not yet.
No, me neither.
Not yet.
Should I? I think I have to. Now?
Now it's perfect. And remember, ask question if you want to discuss. Interact.
Yeah. Perfect. Yes. Thank you very much for the invitation to talk here today. My name is Jan Oldenburg. I'm a clinical oncologist from the Akershus University Hospital, and I'm professor at the University of Oslo in Norway. And I'm going to talk about the patient selection, which is of a cornerstone for the treatment of patients with nmCRPC, non-metastatic castration-resistant prostate cancer. These are my disclosures. And this patient trajectory always starts with a diagnosis of a localized or locally advanced prostate cancer. Usually, these gentlemen are treated with a curative intention. You either irradiate or operate on that patient, and if there is no relapse, then everybody is happy. But if there's a relapse, often detected by rising PSA, then you might do some watchful waiting, but usually you use ADT, and it's only a question of time when the PSA is going to rise. If the patient is healthy enough to live long enough, then the PSA will rise on some time. And then you would assess the patient for distant metastases. And as Nicholas alluded to, it's always the bone scan or the CT scan which you use. If you don't find any metastases, and if the PSA is above 2, it is really rising, then you have the non-metastatic CRPC patient in front of you. There's one different trajectory. It's patients with a localized or locally advanced prostate cancer, which are not considered suitable for curative treatment. These might just start the ADT, and after some time, PSA might be rising. Then you would assess the patient for metastases, for distant metastases, again by bone scan and CT. This is conventional imaging. And if you don't find anything, then you would say this is an nmCRPC patient. So both these groups are eligible for the treatments I'm going to discuss. Again, it's important with the PSA doubling time. It should be below 10 months, according to these 3 trials. And Smith published this for 10 years ago. So the risk of developing metastatic CRPC, and only those who have metastases are at the risk of dying from prostate cancer. It is, I think, impossible to die of non-metastatic prostate cancer. So if the PSA doubling time is getting shorter and shorter, and the PSA is increasing more steeply, then the risk of these metastatic prostate cancers increases quite clearly. So here it looks like it starts at 8 months. In the trial, it was 10 months, which was the minimum. And most of the patients had a doubling time below 6 months. This is also important to remember when you select treatment for patients. So just to echo what has been said about Spartan, Prost, and Aramis, I think all 3 provide excellent benefit of meaningful treatment of nmCRPC. So MFS, the metastasis-free survival, is significantly prolonged, and also overall survival is significantly prolonged, which is probably the most important outcome. These are the 3 compounds we're gonna discuss, and all 3, as I said, improve the metastasis-free survival in this patient cohort. And how do we select which patient should receive which drug? This is not trivial. The doubling time For select between these three, it doesn't play a role because it was very similar. Everybody had to have a doubling time below 10 months. So there might be some vulnerabilities like seizures or the risk of falling or fractures, costs, metabolism as well. So this is an overview from Fred Sart and colleagues who published on the event of adverse events. This is from the Spartan trial, and you see the fatigue is more prominent in those who received apalutamide as compared to placebo. Same for hypertension, diarrhea, falls. This is quite a significant increase, I think. And also joint pain, the arthralgia, and the weight loss, quite a clear increased adverse event frequency. Now we go to the PROSPER trial and enzalutamide. The first impression is, oh, this list is longer. It is. And also the risk of fatigue and musculoskeletal events is higher. It seems to be like that every second patient has gotten fatigue, but also the placebo group, there's fatigue, and these patients, they are older, they might fall and they might have hypertension, but it's clearly increased when you put enzalutamide, if you give these patients to enzalutamide. And cognitive impairment clearly increased if you received enzalutamide and cardiovascular events as well. So here is the Aramis data, placebo. The first impression, again, it's not so many AEs, and they are not that frequent either. And I think also you could say, would agree that the dark columns or rows are not that different from those of the darolutamide. They are more closely together. It's better to see. This is it's just small, but to get an impression, I think here for the PROSPER trial, the risk of AE of adverse events was much higher than in the Aramis trial. But what I would like to draw your attention to is the placebo, the differences in placebo. It's similar to what Nicolas reported. These are three different trials. It's hard to compare them. And he said that he showed that the risk of death reported to, yes, the study drugs that would be either placebo or one of these three drugs was very different between these three trials. And also here we see the risk of reporting an adverse event is very different. So the placebo should be the same. It is sugar pills. That shouldn't be a difference if you have a sugar pill, which is the placebo for darolutamide or enzalutamide. But the AE frequency is very different. So this makes cross-trial comparisons really, really hard, I think. So there was I found an overview review by Maggie and colleagues. And first, the benefits, the MFS is prolonged. I think it looks really similar for these three. Time to PSA progression. I don't think that is too important, this endpoint, but it is shown, and I think it's not a big difference between this. OS, also significant, prolonged, and very similar. So now we come to the AEs, and I think it's the best way to compare the AEs is to look at the additional risk. You have the patients on placebo, that would be your baseline, and any additional adverse event should be attributed to either apalutamide, to enzalutamide, or darolutamide. And you see here, this is an interim analysis of grade 3 to 4 adverse events. So these are relevant adverse events. And in the final analysis, you see the risk of having a grade 3 to 4 AE was more than double as high if you had received enzalutamide or apalutamide. But it was significantly increased as well when you had received darolutamide. So for the serious adverse events, that could be the death or the hospitalization. I think most commonly it's a hospitalization or prolonged hospitalization of a patient. This is interim. This is the final. The impression would be, yes, the risk is more than, or the odds ratio is more than twofold increased. For the RMS, it is increased, but yeah, on the border to significant. And for apalutamide, it is increased as well, but not as high as for enzalutamide. This is an interesting adverse events leading to discontinuation of the trial regimen. And you see it is also happening for placebo. Patients taking sugar pills are taken off treatment because the AEs are considered too serious. So although these patients are really the athletes among the nmCRPC patients or patients entering clinical trials, they are better than those patients receiving their treatment in real world. We know that, and Nicholas alluded to that. So in the final analysis, it is more than twofold as high its odds ratio when you received enzalutamide or the apalutamide. Here, of note, the darolutamide, there was no increased risk to discontinue treatment as compared to the placebo, which is, I think, remarkable, but yeah. Fatigue, any grade, yeah. Grade 3 to 4 fatigue, I think this is probably more relevant. And here again, the enzalutamide seems to be quite hefty. So the odds ratio was higher than 4, but also for apalutamide, it was higher than 3. For Aramis, here it's peculiar. It's on the left side. So grade 3 to 4 fatigue was less frequently reported or registered in the patients on darolutamide than on those taking sugar pills. Dizziness, yeah, it's a similar picture. Cardiovascular events. These patients were selected not to have serious cardiovascular events, I think, so it might be more serious in the real world, but okay. It doesn't look to be a really big difference or really great problem. Fractures are important. And then final analysis, you see the risk to have a broken bone is more than threefold as high if you receive enzalutamide or apalutamide. Here it's 2.7. It's 1.5. It's higher, but not as pronounced, I would say. So this is something which is also worth to consider, the cost of treating adverse events. And there is a difference between the hospitalization or treatment of patients who received apalutamide and the placebo in the Spartan trial. And of these $1,179, more than 1,000 were caused by the apalutamide. And I think here the darolutamide is quite favorable. It's a lower cost for treating adverse events in these patients. This trial is from Neil Shore. I think Bayer supported it, but I think they used the publicly available data. So I think it's okay. It's interesting. So to come to the conclusions, I think for the selection of treatment between enzalutamide, apalutamide, and darolutamide, the benefits are really similar. It significantly improved metastasis-free survival and overall survival, which is important, and also the quality of life. Ian Tannock said there are two important outcomes. It's the OS, how long does a patient live, and the quality of life, how well does he live. So that seems to be very similar for all these three drugs. The remarkable differences are in the adverse events and serious adverse events. And this also includes the placebo, which is peculiar, I think. And I would recommend to select the drug or the treatment based on the vulnerability of a given patient. A patient who is tired, where you think, oh, there is some degree of fatigue already, which is not so uncommon on patients on ADT, then the enzalutamide might be a tough treatment. The darolutamide could be better, but I don't think I can give you a broad recommendation to say this drug is better. I think one have to look into the adverse event rate and also in the vulnerability of a given patient in front of you. So thank you very much for your attention.
Thank you, Jan. As said initially, we will discuss everything at the end. So you highlighted very nicely that the bone is a problem. And Homer, can you elaborate on that? Is really bone a problem, and how to take care of the bone and to prevent bone issues?
Thanks for the question, Nicolas. So I will share my screen, and I hope you will be able to tell me that everything is okay, that you can see my screen. Is it okay for you?
Yeah, that's good.
Great.
Yeah.
So I hope you hear me. Is it okay? And I will start my video as well, so you can see me. Perfect. So hi everybody, and that's a good question, Nicolas. I was asking myself when I received the title of this presentation, why are we talking about bone-targeted agent and non-metastatic CRPC? Why discussing bone-targeted agent in patients that are non-metastatic? But actually, hopefully, I found some points that justify we have such a discussion. So let me present myself before. I'm Mr. Matthew. I'm professor of urology in Rennes University Hospital. And here are my disclosures. So yes, that was my first question. Why are we discussing bone targeting agents in non-metastatic CRPC? Actually, why are we discussing treatments to something that don't exist, actually, bone metastasis in non-metastatic castration-resistant prostate cancer? But actually, I found some answers when I look at what happens in real life when we are doing metabolic imaging by PSMA to patients that are considered non-metastatic with conventional imaging. And what we can see is that some are, in fact, bone metastatic. What is clear here is that in this series, when you're doing an imaging with PSMA, you have almost 25% of the patients that are considered non-metastatic CRPC that actually have bone metastasis with PSMA. But most are not. They don't have any metastasis, and especially no bone metastasis. But we can imagine that bone-targeted agents may prevent development of new metastasis. And what is clear also is that finally, all are under ADT, under androgen deprivation therapy for a long time, and maybe bone protective agent could have a role regarding prevention of osteoporosis induced by ADT. So first, let's talk about this patient with bone metastasis at PET PSMA. This setting refers actually to the stage of metastatic castration-resistant prostate cancer, in which bone-targeted agents have been assessed for a long time. And guidelines are very clear for that. EAU guidelines clearly states that actually you have to offer, we should offer to this patient bone protective agent because probably we had something to the treatment, to the management of this patient. Why? Because we have data for that. First, with bisphosphonate and zoledronic acid, as you can see here, with this study that has been published in 2004 by SAD, we see that in this study, patients who had CRPC with bone metastasis that were randomized to receive zoledronic acid every 3 weeks or placebo, we see that among the patients who completed the 2 years on study, we have a reduction with zoledronic acid of the ongoing risk of skeletal-related events of more than 35%, 36% in this setting. And we also have data with denosumab. Monthly dose of denosumab was afterwards compared to zoledronic acid every 4 weeks in patients with metastatic castration-resistant prostate cancer in this phase 3 trial. And what we can see is that denosumab was superior to zoledronic acid to delay or to prevent skeletal-related events. As you can see here, as shown by the time to first skeletal-related events, that was 20 months with denosumab compared to 17 months with placebo. However, there were no survival benefit with the use of denosumab compared to zoledronate. Whatever, I would say that with these studies, clearly denosumab and acid zoledronic acid are now considered really efficient treatment option with patients who have metastasis and castration-resistant prostate cancer. And actually, the guidelines are clear for these patients. So if you're doing a PSMA imaging, you have bone metastasis. So why don't you treat this patient with actually bone-targeted agents? Because we have data for real metastatic CRPC. We could also discuss about the metastasis-directed therapy with radiation therapy that could be considered as a bone-targeted treatment. We know in hormone-sensitive metastatic prostate cancer that there are encouraging results from phase 2 trials with MDT, such as Oriole or also STORM study. But actually, MDT has been not really assessed in CRPC. And what we can see here from this table in a review published in 2017 is that we only have retrospective studies with oligometastatic prostate cancer on conventional imaging, but also more recently with oligometastatic CRPC with PSMA PET-CT. What we see is that it's only retrospective study. This study suggests that it could maybe delay the introduction of a first-line treatment in nmCRPC, but also delay the switch to a next systemic treatment. But whatever, this is single-arm retrospective study mainly, and we need further investigation actually. And they are ongoing because you can see that there are ongoing trials in this setting, as you can see here, based on SRBT alone or associated with new hormone therapy. There are also other studies that we should mention, just the ARTO trial that is currently ongoing, a trial that is randomizing mCRPC patients to receive as first-line abiraterone plus or not SRBT on all sites of disease. And there is also the degrees style that randomize men to darolutamide with or without MDT. Whatever, it's only 25% of the world population of non-metastatic CRPC that actually have bone metastasis on PET PSMA. So most of the non-metastatic CRPC only have local recurrence and are true nmCRPC. In this population, we know that from the placebo groups of several trials, we know what will happen in the future. In nmCRPC, you have the ability, the potential to progress to metastatic disease in 34% within the 2 years and almost 60% within the 5 years. So actually, they will all progress, or more than half, in the 5 years to metastatic disease. So it could be interesting to discuss if bone-targeted agent would be able to postpone progression to this metastatic status, because we know that MFS is a surrogate actually of overall survival. And we have also data on it because several agents have been tested in this setting. Actually, this figure comes from the result of the placebo group of a study that have been aborted. Why? It's a study that have been aborted. Why? She was asking the question of the role of the interest of zoledronic acid compared to placebo in this nmCRPC. And actually, regarding the low event rate at interim analysis, there were an abortion of the study and efficacy could not be determined. Hopefully, we have also other data from biphosphonate study, and other biphosphonate, as Claude Ronat, have been studied in nmCRPC. As you can see here in this study published by Mason in 2007. And actually, in this phase 3 study, men with nmCRPC that were randomized to Claude Ronat or placebo, when we're looking at the results, with a median follow-up that is nearly 10 years, you have no benefit, neither with bone metastatic-free survival, neither for overall survival. We also have data from other agents, such as endothelin receptor inhibitors, atrasentan and zibotentan. And when you're looking at the result here, nor the zibotentan nor atrasentan give any benefit regarding MFS or overall survival. Hopefully, we have more interesting results with denosumab. In these phase 2 trials, more than 1,000 men were randomized to receive denosumab or placebo, and these men were nmCRPC. And what we can see is that denosumab significantly increased bone MFS by a median of 4 months over placebo. But you can also see that there were no benefit regarding survival. That's why neither the FDA or the EMI have approved denosumab for this indication in nmCRPC. So we have to consider that based on these results, bone active agents, especially those used in nmCRPC, did not show significant benefit regarding bone metastasis-free survival or overall survival. So we cannot recommend this agent for all nmCRPC. But we have to keep in mind that all non-metastatic CRPC are under ADT for several years, actually, and that bone protective agent maybe could have a benefit also on survival or bone progression, maybe in mCRPC, but not in non-metastatic CRPC. But bone protective agent could have a role maybe on prevention of bone loss and bone fracture due to osteoporosis. Because as you can see here, we all know that use of ADT is a risk factor for osteoporosis. But what we see here is that this risk is clearly increasing with the duration of ADT. And we know that patients with non-metastatic CRPC has usually started ADT several years ago. So the problem is that bone loss will also increase the risk, as you can see here, of fracture. So we have to prevent this risk of fracture in these patients that are for several years in ADT. And we also have data to do it because, as you can see here, different biphosphonate, as zoledronate, demonstrated a benefit to prevent bone loss in men with locally advanced and metastatic prostate cancer. And this benefit with zoledronate was true when you're doing this zoledronate quarterly or yearly, actually. But what is also interesting is with denosumab that have been tested in M0 patients with a 6 months dose, and this 6 months dose of denosumab increased the lumbar bone mineral density by almost 6% compared to 1% decrease with the placebo group. And this translates, you can see here, in a significant decrease in vertebral fracture risk on this graph. So that's why, again, the guidelines from ERU are clear. We have to recommend anti-resorptive therapy for men that are on ADT, especially those that are on ADT for several years, if they have a BMDT score of less than -2.5, if they have an additional risk factors for osteoporosis, or if they have an annual bone loss confirmed to exceed 5% as stated here. and it probably represents a large amount of patients with nmCRPC. So in my mind, as take-home messages, some non-metastatic CRPC actually are bone metastatic CRPC when we are doing a PET PSMA, and those could probably benefit from bone-targeted agent to prevent skeletal-related events. Actually, most nmCRPC have no distant lesion, either on conventional imaging by definition, but also with PET PSMA. And for this patient, benefit of bone-targeted agent is not proven. But we have to keep in mind that all these patients, all these nmCRPC are under androgen deprivation therapy for a long time, for several years, and many probably will justify the use of bone protective agent to war again this bone loss and to prevent fracture. Thanks for your attention. And Nicolas, I give you the micro to ask some question to our audience.
Thank you, Romain. Very nice talks, both of you. So we have some questions, and it's nice that you elaborate a little bit on PSMA. That was the first question. Before to ask that, there was a question regarding when to change therapy. And the question was, let me be sure, have we to appreciate disease progression not on PSA progression, but on imaging instead? And I already answered that absolutely yes. PSA progression per se, at very best, suggests that you need to consider re-imaging. But please, please don't change any therapy just because the PSA is rising. None of the trials, neither on non-metastatic nor on metastatic CRPC, have ever done that. If you do it, you will lose time, you will switch therapy far too early, and you will switch therapy without having all their benefits, and only change if there's a symptomatic progression or a very clear imaging progression. That is really what has been done in all the trials. These are the guidelines from the ASCO, from all the medical societies, the oncological societies, and absolutely don't change just based on PSA. Now a question for both of you. I must say I was a little bit surprised by your talk, Romain, but what is the real place of PSMA PET in the non-metastatic CRPC? Implicitly, you suggested that it might have a place. So I would love to have your view, and then Jan, to have your view too.
Actually, if we want to define a non-metastatic CRPC, we should not use metabolic imaging. But actually, in the history of our patient, there are many, and Jan told us that some are relapsing after local treatment. And actually, some of them are relapsing, had non-androgen deprivation therapy, but already had an imaging, a metabolic imaging. So in real life, there is a lot, I think, in my practice that actually have a conventional imaging that is negative. We have no metastasis, but actually also come to the office with a metabolic imaging and a PET PSMA, actually, that was done in practice. And that's the main problem, because we have a conventional imaging that is negative, but we have bone metastasis in I told you, 25% of our patients. So that's real life, and we are talking about real life. The question was about bone-targeted agent. Maybe it's this slot of patients that could benefit from BTA.
So clarify your view. Would you personally prescribe a PET PSMA in a non-metastatic CRPC? You discussed nicely patients that come to you with a PET PSMA already done, but do you prescribe PET PSMA?
In my practice, I don't prescribe because I want to be in the guidelines, and the way I want to be in the guidelines, I'm doing conventional imaging to be sure to clearly define patients with castration-resistant prostate cancer. And if we want to define them, we have to use the conventional imaging as stated in the guidelines.
Perfect. Jan, your view?
Yeah, I would agree that I think we have to stick to the conventional imaging. It is true that a lot of PSA pictures are taken, but their role and indication is hotly debated. And you might sometimes benefit, but you easily can hurt the patient by starting a treatment for which you don't have the evidence. And I think if you find a bone lesion in a patient which doesn't have, which is nmCRPC on conventional imaging, I would not think that this is important for bone protective agents. I think that the big question is, and Roman, you showed that very nicely, the longer the patient was on NET, very few patients had a normal bone density, and the osteoporosis did increase. After 8 years, nobody had normal bone, which is quite impressive. And if you then add darolutamide, enzalutamide, or apalutamide on top of that, how much more pronounced would the bone loss be? That would be a really good question, but I don't know if these are assessed. Probably not, because that would be really good. Yeah, my suspicion would be the bone loss is more pronounced. The patient are on a more intense castration treatment, and I would expect that the bone loss is more pronounced, and the patient live longer with that disease. So I think you will accumulate more SREs in the end. And so it's a really important topic. Yeah.
I must say I agree. There is a question from an anonymous spectator, what the recommendation of EAU for giving bone protective agents in non-metastatic. To be honest, we don't have a specific line on that. What we do have is specific lines on bone protection when you treat with ADT, and the drugs are important, but please never forget all the other bone health methods, that is losing weight, practice exercise. Exercise might be as effective as bone protective agent for osteoporosis prevention. That's the case. That's the key. Regarding the PET PSMA finding bone mets, I would be a little bit worried to start at that time denosumab, which seems to be the most effective drug, one injector every 4 weeks, because we know patients will live for several years, and we know that usually after 2 years of denosumab, we have to be very careful about of the jaw necrosis, which is really an issue. Jan, you wanted to say something? Yes,
it's about communication with the patients. I think it's both on the PSA, because when the Spartan trial was at our hospital, the consultations were so much easier because the patient didn't know the PSA answer. So it's a lot of talk about a molecule which might not have so much importance for the management of the patients. So I think it's beneficial to explain the patients before they start on ADT, and also before they start on one of these drugs, that the PSA will rise again. This is not a crisis. I'm really tone down the excitement when the PSA is falling, because it will turn around. And if you celebrate a falling PSA, then you will have a hard process when it's increasing. And the other thing for communication as well, it's training. You have, if you are in space as an astronaut, you will have osteoporosis. The longer you are up there, the more osteoporosis you have. And I tell that my patients, and it is important to use the bones, actually. And if you do a lot of swimming, athletes, they have more osteoporosis than those doing soccer or something else. So it's really important to have some impacts sometimes.
That's a good point you highlight, Nicolas, is that the fact that probably we will only have the opportunity to give the bone protective agent and the denosumab for only 2 years, and we don't know if the earlier is the better. So it's quite of discussion also with the patient, because we don't have the data to say, okay, we have to do it the earlier, and probably we could also postpone the introduction at the real time of nmCRPC with the conventional imaging.
Mm-hmm.
There are several questions regarding PET-PSMA, but that's not exactly the topic of this session. But there's a question that is very wise. In a poor technology environment, and that's a question for Mathieu, for Romain. In a poor technology environment, can we base bone-targeted agent therapy on the duration of ADT?
That's a wise question, actually. What is poor technology environment? Actually, it's quite easy normally to assess bone mineral density, and actually, as you can see, with bone mineral density with a T-score that is less than minus 2.5, you can introduce the bone protective agent based on the semester dose or yearly dose of biphosphonate, for example. So I would say that you don't need so much technology, but you can base also with the clinics, and we know that when you are over 5 or 6 years of ADT, you are at increased risk of being with a significant bone loss, and you probably actually have an opportunity to give in this specific environment BTA, especially because when you are with a dose that is a preventive dose for bone loss, you don't have so many adverse events, and probably the benefit is over the AE of protective agent adverse event.
Perfect. A question now for Jan. Do we consider in the same way patients with a doubling time of less than 3 months and those with a doubling time around 9 months? Or should they be treated in some different way?
No, I think they should be treated with one of these 3 drugs. It's a good question, and you might suspect that the patient will relapse earlier, but this is not proven. So I would treat these patients independent of the doubling time, but it is important to have at least 10-month doubling time. That would be my main concern. That if you shouldn't treat doubling time, which is above 1 year, for example. Then you will have really high number needed to treat to benefit the patient, and you might easily harm the patient as well.
And if I'm correct, it has been proven now, at least in one trial, that the benefit is the same, whatever the PSA doubling time, below or more than 6 months, benefit seems to be exactly the same. So there shouldn't be any difference.
Yeah.
We are 5 minutes late, but I will try to answer to one question, which for me is of major importance. What the explanation of high adverse events in placebo arm? That's a major question, because well, when you do a trial, you are very, very careful about everything. So probably you over record things that probably in your clinic you would not record.
Yeah.
Might be a mistake or not, but you over-report side effects. That's the first point. The second point is, in the control arm of 3 trials with sugar pills, saying this officially with placebo, which is almost sugar pill without any sugar, you might expect to see exactly the same thing. If you see huge differences between the trials, it's purely by chance. It probably represents the fact that the patients included in trial A and in trial B are not exactly the same. So it's a very important point to highlight that because of that, you cannot directly extrapolate for a trial to another trial, just because it was not randomized.
Yeah.
But the side effects you see from the placebo arm are high just because you ask for them. Don't tell me then in the clinic you will ask all the same questions that you do in a trial. That's not true. We should, but we don't do. That's it. For me, it's a very clear example of the huge difference between trials and real life, and that's why we need real life. Romain, Jan, do you have a very last word to add?
No, but I would agree that there is a big difference between trial patients and real life patients. And usually the benefit is much lower in real life and the toxicity is much higher. And then we are not that observant. We don't ask that much. That might be really problematic for vulnerable patients. So yes, I agree.
So that's why when it is valuable, we have to turn clinical trials into real life, but we also have to report what happens in real life, because it's really, I think, one point that should be more discussed after a clinical trials is reported.
I agree.
Yeah,
I agree. Phase 4 trials. I did read that when looking at the AEs, which I did not do that detailed when I did read the papers for the first time. Now I had to prepare this lecture, and I thought, wow, the AE rate is so different. This why? Yeah, these trials are independent, but you probably will have a lot of more AEs and you will not handle them as well as in a clinical trial. So it's really important to select patients and not start just something.
Agree. So we are behind schedule, not that much, but a little bit. So I would love to thank you both for this interesting discussion on a major topic, non-metastatic CRPC. I must say I was very interested to see that there were a lot of questions regarding bone protection, which is far away from what we see in real life, let's say at least where I work. And I'm quite sure it's the same almost everywhere. And I would love to thank also Bayer because they allowed us to do this and we were absolutely free to say what we wanted. So have a safe evening and hope to see you later, hopefully in Milan or EU. Bye-bye.
Bye-bye. Thank you very much.
Thank you very much. See you.
See you.